Our next speaker is Dr. Lindsey Jasinski with Elizabeth Riley. Lindsey is the Associate Professor of Psychiatry at UK with appointment at Eastern State Hospital. Ms. Riley is a UK consortium intern who has completed major requirements for her PhD. Their topic, how the SMART program, self-management and recovery training, can help those living with opioid use disorders. Please welcome them.
All right, well, I'm Lindsey Jasinski, so I am joint appointed between Eastern State Hospital and the Department of Psychiatry. So in the past 6 months, I've actually taken some of my time and been working on some program development in the outpatient clinic. What we are working on is related to what Dr. Brenzel actually shared earlier, and that is we have some core grant funding that has come through the Department of Psychiatry, and we've taken that to develop some additional programming in the outpatient setting. So this would be the component of what he talked about with the office-based, treatment. And so the program that Elizabeth and I have been working on is really addressing that availability of what was formerly known as medication-assisted therapy, or now medication for opioid use disorder, and integrating that with services that we know are needed with this population. So it could be group and individual psychotherapy, case management, peer support, all of those services, so that we can have one comprehensive practice where those services can be provided. Elizabeth has been working with me for about the past 8 months or so on this program development process. So I'm going to let her talk about the program. She's done a ton of great work, and one of the privileges that I have as a psychologist both at Eastern State and UK is supervising students who get to then showcase the work that they've been doing as well. So I'm going to allow her to talk about a lot of the program philosophy and just the way in which we've gone about integrating both research and practice so that we've created the infrastructure for looking at data as we move through this program.
All right. All right, thank you so much to Lindsey and to all of you for letting me be here. I'm really excited to talk to you about this program that we've been working on developing. Personally, myself, I'm really kind of split between research and clinical practice. I really love doing both of those. And as Lindsey was indicating, I think this program is a really kind of great and exciting marriage of both of those two areas of the clients that we serve. So here we go. There we go. Good. My clicker is working. All right. So the purpose of this talk and of our time together is to very briefly review the scope of the opioid problem in Kentucky. This will not be a thorough review, just very brief introduction. Talk about medication for opiate use disorders, kind of again give a very brief introduction to those for those that may not be as familiar. Talk about the systematic application of program development principles. That's something that Lindsey and I have been working a lot on, is really making sure that the development of this program is systematic, theory-driven, research-based, and making sure to integrate research into every level of our program development. And then finally, the last part of this talk will be to introduce the SMART program, which we're really excited about. We're excited to get opening here in a couple of weeks. And so I'll talk a little bit about both the program philosophy, the structure, the research infrastructure, as Lindsey said, that we are both building and integrating and hoping to expand. So again, just a brief introduction to the opiate crisis in Kentucky. I'm sure a lot of you guys have heard this term, opiate crisis, and I'm just going to do a brief overview, but this one thing I'd really like to start out by saying is that this is a very, very broad problem. It's not one thing in particular, but Kentucky, this is data from the last couple of years, Kentucky has the third highest in the nation in opioid-related overdose deaths. That's about double the national rate. You can see some kind of increasing trends there over time. And opiate use, for those that may not be totally familiar, involves a lot of different types of medications, a lot of different types of drugs. So certainly it can involve prescription opiates, things like OxyContin, Vicodin, codeine, morphine, and also illicit opiates, things like heroin and especially fentanyl. I'd like to draw some attention to fentanyl, which has been increasing in its severity, increasing in its prevalence among a lot of our patients, both among primarily opioid users, and also fentanyl is popping up in a lot of stimulant medications and a lot of other illicit drugs. So fentanyl is kind of its own special crisis in and of the opiate crisis broadly. And Kentucky has traditionally had an extremely high rate of painkiller prescriptions. There's a lot of reasons for this that can't talk about all of the overall trends over the last couple of decades, but one thing I think is important to highlight is that in the 1980s, there was a culture shift a little bit in the medical community of treating pain as a vital sign, and so treating pain, particularly using opiates, became a lot more common. In the 1990s, companies like Purdue Pharma, who manufactures OxyContin, were really advertising opiate prescriptions as non-addictive. We now know that to be certainly untrue, but there was a big increase in opiate prescriptions over the last couple of decades. And although we talk a lot about the prescription opiates, most of the deaths that we're seeing, most of the overdose deaths, are actually from illicit opiate use, so things like heroin, fentanyl. And one thing I would like to point out is in that graph on the right, there's that little big red arrow that's pointing down at 2010. And so at that time, there was a major shift in prescribing guidelines. There was also a shift in how OxyContin was manufactured, making it more difficult to extract the illicit drug from that medication and snort it. So then people started shifting a lot towards the more illicit types of opiates. And that's one of the hypothesized reasons we saw such a huge spike and such a huge increase in the death rate around that time. So in the last year, there's been $40 million in government funding directed to the opiate crisis in Kentucky. This does not include the huge grant that was just awarded to UK. It does not include that money, but prior to that, it was about $40 million. One thing I think is really staggering that I would like to talk about is that in the first couple of years, of when we're really talking about this opiate crisis, no states had a statistically significant decrease in the death rates from opiate overdose, which I think is staggering considering the amount of money that we as a society have been pouring into this problem. But and only 4 states had a decline at all. So I think that we're really talking about something that, despite all of the funding that's being poured into this problem, we haven't yet seen a whole lot of results. Hopefully that will change given the massive grant that was just awarded. So that is one of their target goals, is to reduce overdose deaths from opiates. But one thing I would really like to talk about is the difference between the overdose crisis and the addiction crisis. Because overdose deaths from opiate use disorders are really just a marker of the disease burden, but certainly they don't capture the entire disease burden. Opiate addiction, it's estimated, at least, there's not perfect data, but it's estimated that for every opioid overdose death, there is 20 to 30 overdoses that do not result in death. They can certainly result in neurocognitive impairment, something that we see a lot at Eastern State. They can certainly result in medical complications, which has been a big learning curve for me. I know things like the folks that we're seeing in our clinic, a lot of IV drug users have so many medical complications that are a huge burden on their medical health and the medical system in general. So, and then that doesn't really speak at all yet to the massive amount of psychosocial burden that we're seeing for these patients, for their families, and for the entire communities. And so I think that even though we often talk about the overdose death and the overdose crisis as a really important part of the opiate crisis, which it certainly is, I think we need to not forget the fact that the overdose death, the death rate, does not fully capture the disease burden of the opiate crisis in general. And then the last point I will talk about on this piece is that we think about opiate use disorder and folks who are using opiates, but most people that we're seeing are polysubstance users, whether that be marijuana, whether that be stimulant medication, whether that be stimulant illicit drugs. There's been a huge increase in methamphetamine use in our opiate use disorder population. So I think that's something that we're also kind of grappling with as we continue to develop this program. So a brief introduction to medication for opiate use disorder. So there are some FDA-approved medications for opiate use disorder. I'll run through these really quickly. Methadone, which is probably something that many of you guys have heard about. Methadone clinics were very popular and still are. They're still in existence, but that was one of the frontline first initial treatments for opiate use disorder, particularly back in the 80s and 90s. Not as common now. One of the major drawbacks of methadone clinics is that methadone does need to be prescribed in a specialized clinic, which makes it difficult to access care for a lot of patients, particularly in a state like Kentucky that has fairly low population density outside Louisville, Lexington, and Cincinnati. Another FDA-approved medication is naltrexone, which is non-addictive. It's an opioid antagonist. So this would be something like Vivitrol, which we will sometimes see at Eastern State. One major drawback to this is that it doesn't protect against withdrawal symptoms. So people do oftentimes have to go through a full withdrawal in order to be prescribed Vivitrol, which is really, really tough for a lot of our folks because withdrawal from opiate use disorders is pretty horrifying and also lasts quite a long time. So it's not a great fit for a lot of patients, particularly patients who have high psychosocial burdens or who have high other medical complications. So it's not necessarily a great fit for a lot of our patients. And the last one I'll talk about, this is really the most common medication for opiate use disorder that we see in our clinic in the SMART program within UK Psychiatry, and that's buprenorphine. So, or a Suboxone is typically the name that we'll hear. It's a combination drug, buprenorphine and naltrexone. So it increases the safety in case of an overdose. It does not force the person to go through a medical withdrawal from opiates, and you're able to be inducted and stabilized on the medication fairly quickly. So there are 3 phases. There's an induction phase, a stabilization phase on buprenorphine or Suboxone, and then a maintenance phase. And so when I say maintenance, that can really vary based on the patient, both in terms of how much Suboxone or buprenorphine they're taking and how long they're on it. We do have some patients that eventually want to titrate off of Suboxone or a like medication, and there's some patients who are able to maintain their consistent level of Suboxone for years and years and do really well. So even though there is this maintenance phase, it really looks different for a lot of people. And so that's something that we are also kind of considering and always thinking about in our program development is what really maintenance looks like for people and how to think about that and how to talk about that with them. So the program development model that we really have been hoping to implement and have been implementing really for the last 8 months. We've had so many iterations of so many things. Lindsey and I were just talking yesterday or a couple days ago about, how we were remembering how we were thinking about just the name of the program back in November and how much things have changed and how much things have grown just in the last 6, 7, 8 months. It's been pretty amazing. But the model that we've been using for program development is this idea of plan, design, implement, measure, and then that's a cycling model. So I think that's a really important part of program development, particularly for a program development that's essentially designing a treatment program for which there is no gold standard of evidence-based treatment quite yet. I mean, we certainly have things that are evidence-based and we're integrating those, but there's no real one way to do it because this is such a multifaceted problem. And so I think one of the things that Dr. Jasinski and I have really been working on is this idea of planning something, designing it, implementing it, and then evaluating it really closely and seeing if it works. And I think this is a really important part of program development, this idea of not necessarily being too attached to any one way of doing it because that might not work, and really letting the data speak for itself. And that's what we're hoping to do in this clinic is collect a bunch of good data, analyze it, and then see if it's working, and then redesign our program based on what the data are saying. So hopefully it is clear by now that there's a very big need to address opiate use disorder across the state in Kentucky. We did get some grant funding, quite a bit of grant funding, to assist in the development of a comprehensive program integrating medication for opiate use disorder and therapeutic interventions to maximize outcomes and to collect data on those outcomes. So we're hoping to provide care more efficiently and in kind of one centralized location, really having a treatment home for patients without compromising patient care and really hoping to enhance patient care. There is ongoing addiction treatment services through UK Psychiatry, and there's a lot of providers, a lot of physicians that have been doing really great work over the last couple of years. And one of our goals has really been to create a structured and standardized program within UK Psychiatry for a lot of reasons. One of those reasons is actually to collect data and be able to do good research on how the program is developing and going over time. Because right now, when we have a lot of different prescribers, a lot of different doctors, they're doing things pretty differently. It's hard to really gauge what's working well and what's not working well. So hopefully by standardizing and integrating and structuring the program, we're able to have patients have a very similar experience, have a standardized experience, which is really good in terms of reducing power struggles and reducing all of those kind of clinical barriers that do come up, and also allows us to collect really good data. And with that data, we're also hoping to really integrate fully this idea of research and practice. So we're certainly having a very fully fledged ongoing clinical services team, but also integrating other grant-funded research projects. So we're collecting data on our own program and also integrating data and research projects that are grant-funded from other areas. And so we're hoping for this to be a very vibrant research-based clinic, and to have that be a really big part of the message that we send both to our clinical services team, to our staff, and to the patients. We're really hoping to kind of create a lot of buy-in for research, something that, Lindsey and I just led a group last week, I guess, and something that we heard over and over again was how much the patients really wanted to help other people who were in recovery. These are patients that are currently in recovery. And so we're really conceptualizing and thinking about their participation in research being patient-centered and being a way for them to give back, improve the lives of other people as we work to develop this program. We're hoping to have them be able to do research projects. We're hoping to have focus groups for the patients to be able to tell us what's working well, what's not working well, and really create a culture where we integrate this research and practice. One other thing that I would like to talk about is certainly giving credit where credit is due, and that is to the COPE program, which is at WVU, which is West Virginia University. Lindsey and I went out there in October and watched their model. So that's the model on which our clinic is very loosely based. We're hoping to do a few things similar, a few things different. But one thing that they do is group medication management for medication for opiate use disorder. And that's something that we'll be integrating as well. I'll talk a little bit about that in a second. So some core components of the SMART program, which again stands for Supportive Medication-Assisted Recovery and Treatment. That was one of our therapists that came up with that name, which we were really excited about. So the core components include combining medication for opiate use disorder with behavioral health and psychological treatments. So Lindsey and I are both psychologists, or I will be at some point in the future, but as psychologists, we really like this idea of integrated behavioral health care and really important psychological care for these patients. And really thinking about the fact that recovery from a substance use disorder, particularly opiate use disorder, is not just sobriety. It's a whole lifestyle change, and that's what we're really hoping to build in this program by making a comprehensive program. And this approach teaches clients skills for not just recovery. Recovery is related to all of these things, but certainly things like coping skills, emotion regulation, interpersonal effectiveness in relationships, and maintaining health behaviors. So one thing that, a small way that we're trying to do this is we're actually trying to provide snacks and healthy snacks for people when they come to the clinic, making this much more of a clinic home. So having things like granola bars, just introducing the idea that healthy breakfast can actually improve your ability to engage in treatment and things like that. So we're really hoping to create this integrated system of care. So we have a very comprehensive intake process that will include certainly a medical intake done by the physician, psychiatric and psychosocial history, and then also one thing that we've recently added is this idea of a battery of cognitive strengths and assessments. So one thing that we know exists but don't know a whole lot about because the literature is pretty new is the cognitive impairments that are inherent to a decades-long substance use disorder. And cognitive impairments can include things like working memory, language, and that can really impair or affect somebody's ability to engage in treatment. So that's really what we're hoping to capture in this cognitive strengths and challenges assessment, is to see what parts of treatment might work really well for this person, what parts might be more difficult, and to try to make treatment individualized, but also data-driven. So we want the treatment to be responsive to somebody's strengths and weaknesses cognitively, but also to know that not just, oh, this person seems to struggle, we're actually gonna have data to be able to predict that and inform that. And then treatment through the SMART program involves 4 components. So the first is the patient's self-report of substance use and random urine drug screens and pill counts. That's something I'll talk about in a little bit. We have group medication management. We have a values-based group psychotherapy, and then outside recovery-based activities. I'll talk about more of these in detail, but these are the 4 core components that is integrated into every clinic visit and every patient's treatment plan. The main principle, the main component of our program is this focus on honesty. And for those of you that have worked with patients with substance use disorders, particularly opiate use disorders, you may know that dishonesty is a really big part of the pathology of the disorder. And that's, it's something that people and patients have used to survive for years and years, and it's really a pattern of behavior that we're hoping to shift and change through our use of what's called a recovery update form, which I'll talk about in a little bit. But basically the idea is that we can't give good treatment if we don't know what's going on with our patients. And the way to allow them to be honest about their substance use, honest about what's going on for them, is to be able to not have a punitive result for relapse. We know that relapse is a part of recovery. Recovery is not a linear process. It never is. It never will be. And so what we really want to be able to communicate to our patients is that relapses are going to happen. What's most important is that you talk to us about them, you talk about why it happened, and we can help that not happen in the same way again. And so patients aren't kicked out for relapses. They're not kicked out for 3 relapses. They're not kicked out for 5. I mean, we're going to increase care, we're going to increase services, but they're not discharged, they're not kicked out of the program for relapse. And I think that's something that's really shifting and really changing in the substance use treatment world, and that's a really, really important part of our program as well. So the group medication management meetings are really interesting. This is a novel way of doing medication management for substance use disorders. Basically, these are 30-minute group meetings led by the prescriber, led by the physician, and it's a group of 8 to 10, 8 to 12 patients, depending on the size of our clinic space. Right now, it's really capped at like 10 to 12 people. And so what we do is we're going to stratify these groups so that the patients in the group are at roughly the same stage of recovery. So we have this kind of like early recovery group and advanced recovery group, which as we grow, we may stratify even more. Lindsey and I have a lot of ideas about how to do that. But basically right now, we're going to group together patients that are in the first, I would say, like year of their recovery into an early recovery group, and then everybody else is in a more advanced stage of recovery. And so this is to give some similar experiences, to allow people to connect to each other and really allow a cohort model of group development to occur in these management meetings. And so in these meetings, which are again are led by the physician, they'll review the number of days they have sober, any recovery activities that the patients have engaged in, any problems with medication, side effects, things like that. And really one of the big benefits of this is to have patients allow to learn from each other and to learn, okay, you know, you had this side effect, this is how you're handling it, this is a problem, I'm not alone in this, to be able to connect with each other, and for the physician also to be able to see patterns among his or her patients. And again, one important point of this is that this group medication management does focus only on medication for opiate use disorders. A lot of our folks have other high psychiatric burdens, but this isn't the place where they talk about the medication that they may be taking for bipolar disorder or things like that. This is just for the medication for opiate use disorder. One thing that is immediately after the medication management group is an hour-long group psychotherapy session. Again, this is a group session. It's the same people, so the patients all come into the clinic at like 8:15 or 8:30. I have a schedule that I'll show you later, but they all come in together. They go to a half hour of this group medication management, and then they immediately transition into an hour of values-based group psychotherapy. And so each patient attends group every single time they come to the visit. So we're really trying to send this message that psychosocial care, psychological care, coping skills are on par with and equally important to the medication that they're taking. Because again, recovery is not just sobriety. It's a lifestyle change. It's a lot of skills, a lot of things that we're building over time. And so this is their clinic visit. This is actually the bulk of their clinic visit. So we're going to teach them skills and talk about things for coping, emotion regulation, healthy living, relationships, things like that. And really the reason we're using a values-based framework is because we know that values are an incredibly important part of motivational interviewing, which was one of the main treatments for substance use disorder. And it allows for what we're hoping to achieve is a really nice continuity of care in the sense that wherever you are in your treatment, whatever stage, whatever week, whatever day, you're still going to be living a values-based lifestyle. And maybe during the first couple weeks of your recovery or the first couple months of your recovery, that value is just staying sober. It is just avoiding the people and places and things that are triggers for your recovery, and that's okay. That's an important value. Maybe as you continue on, achieve some more stability in your recovery, your values are more about family or more about healthy living or more about church or whatever it is. And so, but the idea is that at any stage in your recovery, it's really values-based living, and we're going to meet you where you're at to talk about what that means for you and how to best achieve that. again, with the values, we're big on the values. So the other really, really important component of this program is that we do require our patients to engage in values-based outside recovery activities. So this is a pretty common model in some substance use clinics in the sense that a lot of people will require AA, NA, some sort of 12-step or Celebrate Recovery type meetings, and that's a pretty common model. One thing that we think is unique about our program is that we're really trying to conceptualize outside-based, recovery-based activities more broadly. So thinking about the fact that for some people, AA, NA, Celebrate Recovery, that works great and that's important. And if you want to go to a meeting every day, that's awesome. But if that doesn't work for you, maybe going to Bible study or maybe going to a parenting class or maybe doing volunteer work, that's just an important part of your recovery and that's okay too. And so we're really trying to pilot this model, thinking about recovery and recovery-based activities more broadly as a way to support people's ongoing recovery. Again, recovery is not just sobriety. So hopefully you'll be able to see this. This is an example of the first part of our recovery update form. So every time a patient comes into a clinic, they will fill out this form. And this is that kind of honesty check that we talked about. So on this form, they will fill out things like some psychosocial variables. They'll talk about any substances they've used. We're really interested in things like alcohol use, cigarette use, all sorts of substances. We know that almost all of our folks are polysubstance users, and we want to be able to capture that even if we're not addressing that directly. And so this is and they're also able on this form to give us some information about any major psychosocial changes. Something that we know happens a lot for our folks is evictions, job losses, overdoses for themselves or other people. That's important and we want to know about that. So they'll fill this out every single time they come into the clinic visit. And the really important honesty piece here is as long as their urine drug screen matches what's on this form, we're cool. We're good. We're going to talk to you about the relapse, absolutely, and that's important. But as long as you are honest about the relapse, as long as you're honest about what happened, we can help you and we can serve you well. But if there's a discrepancy between what they put on their honesty form for what they're used and their urine drug screen, that's when we're going to have an issue, and that's when this dishonesty piece comes in. So this is kind of our honesty check, and it's a way to, again, capture good data. We're still working on building that research infrastructure to be able to track this over time, but that's something that we are working on. So for the intake and assessment procedures, one of the big goals of the SMART program, as I've said a bunch of times, is for it to be research grounded and to really provide data-driven clinical care. That's our mission and that's our big goal. So we have this comprehensive initial encounter talking about medical, psychosocial, and cognitive screening needs. And then we also have continued assessment at regular intervals throughout the program. And we think that this is another important piece, is this idea that we're talking about continued assessment, continued data collection, and continued refinement of the program based on how we're doing. So a lot of these measures may or may not be familiar to you guys, but this is what we're doing. This is our plan. Our plan to implement very, very regular assessment measures at intake, at 1 month, at 3 months, at 6 months, at every 6 months. I mean, we anticipate that we might have some folks for a couple of years, and that's okay. We just want to be continually assessing them for a bunch of different things, a lot of psychosocial measures, and also cognitive measures. So each patient is in the clinic for approximately 2 hours. So they have 30 minutes when they first get there for the urine drug screen, that recovery update form that I introduced. And then another thing that we're really excited about piloting is this idea of a mindfulness meditation, really starting the day with intention. So it's also kind of convenient because that's when we're going to do our team meeting. But when we're doing our team meeting every morning, the clients and the patients are actually doing a guided meditation to really try to set the tone for recovery as being the emphasis of that day. They have 30 minutes of group medication management and then 60 minutes of that values-based psychotherapy. There's also structured treatment phases. So we have movement between time and recovery is based on both the amount of recovery that they have sustained and their therapeutic process. So really trying to, again, make this a very data-driven procedure, not just like, oh, I think you're ready, therefore you can go down or you can bump down in care or whatever. But basically, patients or the teams can request increased services at any stage if patient is struggling, but there's this idea that they move through the program in a structured way and in a way that's capturable by data. Relapses will prompt increase in services, not discharges, but increases in services. And then we are also piloting what Lindsey and I are really excited about is basically this application for a patient to move up in treatment or move down in treatment, however you want to think about it, basically advance through the treatment phases. So decrease in clinical services team. Basically, the patient is going to be the one that says, I think I'm ready to decrease my level of services. Here's why. Here's all the things that I've done. Here's how I'm doing. Here's why I think I should be able to decrease in services. And then they'll bring that to the treatment team. Again, kind of allowing the patient to take charge of their recovery. Here's a quick overview of the phases of the intervention. So we've got weekly clinical contact visits. So for the first about 3 months of what's happening, they're going to have weekly visits, then they'll move to bi-weekly visits every 2 weeks, monthly visits, and then quarterly visits. And again, that's the time that we're anticipating patients will be in that phases. But again, we're piloting this idea that the patients will apply to move down in treatment levels. Here's a quick overview of the program schedule. I know we're close to time, but basically there's 2 blocks, this early recovery and advanced recovery stage. So they come in, mindfulness meditation / team meeting, med management, group psychotherapy. And this is their routine at every clinic visit. Currently, we're planning to enroll about 115 patients into the program in July. We have this integration of comprehensive research into our program. We've got a couple of big grants that we're hoping to get scored here pretty quickly and integrate into our program of care. And then also we're really hoping to establish a research infrastructure to be able to collect data in a way that's not a burden to the patient at all, but using their de-identified and regularly collected data to be able to drive that clinical care. And then we also have lots and lots of ideas about how to increase care in terms of more specialized services. So additional groups for parenting, for insomnia, for depression, for things like that. We've got a lot of ideas that we're hoping to expand also pretty quickly once we get going. And then also thinking about building this continuum of care to include both an IOP, maybe that we do, maybe that somebody else does. We're still working on that. And also partnering with other agencies that work with folks in different stages of recovery. So places like the Bridge Clinic, which takes patients from the ED and then transfers them to more comprehensive care. And then we're also working hopefully on integrating with primary care, GI, and pharmacy. We're hoping to eventually have a pharmacy on site. That would be awesome. Something that we're working on to try to, again, create this medical home for people. And last but not least, we're doing, hopefully we'll do a lot of future opportunities for research, exploration of outcomes and predictions of different phases of treatment, predictions of engagement versus disengagement in recovery activity. It's something that we're excited about. And then creating and supporting an echo model for mid-level providers and practitioners in rural areas, given that this is a low population density state. And then again, we'll continue to evaluate our program. We'll continue to refine. We'll continue to collect data. We'll continue to get feedback from patients as the research progresses, both in our clinics and in the field broadly. We'll continue to both refine and change our program based on the clinical data. So, all right. I think that's it. Thank you very much.
Have you researched to see if there's a difference in people taking the Suboxone pill and people taking the film? Because I do case management with Medicaid, and when we went to the pills from the film, we had a lot of people that complained and said that the film worked better for them than the pills do.
Of that, and actually the direction that we're moving now is into the injectable, and so that's probably where the practice will go. It's a 30-day injectable. I can't tell you the exact data on that, but we do have some of that sort of feedback from patients that there's differential responses to those. We use mostly the strips.
Yeah. Okay.
So we really don't use pills, but we are moving into the injections.
Okay. Thanks.
Go ahead, Zen. Just yell really loud. We can hear you.
Thank you for such an exciting presentation. And I really like the program evaluation piece. I was wondering if you are finding any differences or anticipate differences between those with comorbid psychiatric illnesses in terms of being able to participate, outcomes, things like that.
Anecdotally, I would say yes. So it probably wasn't clear. We have about 115 people that we're treating within the outpatient clinic right now. So we've been working with them some, but the full program, in terms of all of the group medication management and group therapy, will be operational in July. So they're mostly seeing individual providers right now. We do see that as a niche area for us compared to some of the other Suboxone clinics that are in the community, where we can, because we're linked with the Department of Psychiatry, treat those comorbidities. Yes, I do think anecdotally it's much harder for those folks to progress through treatment in a linear way, and that's something that we're set up to measure over time. So that will be one of the variables that we capture.
We're really excited to be able to provide treatments such as trauma treatment or things like that, as you said, I mean, might make it harder for patients to engage or pace differently throughout the program. And so I think that that's certainly something that we're interested both in capturing in this initial phase, and then hopefully eventually providing targeted and direct treatment for something like PTSD or anxiety or depression in addition to the opioid use disorder.
All right. Thank you.
Thank you.